Yeah, so good afternoon, everybody. And my talk is not on Octa, but on OCT, the routine OCT that we have, and how artificial intelligence is changing the way that it has increased its applicability in a lot of clinical situations. So I have no financial disclosures. Now, OCT, as we use it, we get printouts like this, or we go to the machine and scroll up and down on a macular cube. So you get good visualization of subretinal and intraretinal structures. You also have a reasonable amount of qualitative and quantitative data. But most of our decisions and perceptions currently are made on qualitative assessment, not only on the numbers. And there's a huge quantity of data that is ignored, especially in quantification. So if you look at quantification, we usually look at the CMT or subfield thickness. We very occasionally do look at the retinal volume also. But most of the time, if we have to measure, we go for manual measurements. That is because a lot of times the segmentation is off. And we use predominantly quantitative data for temporal comparisons. Most quantitative measures are non-specific to the pathology, like macular edema, or for that matter, intraretinal fluid can be present in several pathologies. So it's not very specific. And the limitations current system are that, depending upon the system that you are taking a scan on, there are scan variabilities, there are artifacts, and whenever there is a cataract or a media opacity, the low signal to noise ratio makes the interpretation of the OCT difficult. You have erroneous segmentation. So, for example, in this particular example that I have showed, the system will actually tell you that there's an increase in the thickness rather than the actual decrease that has happened. Also, there is a lack of software to segment the individual components of a disease. For example, I'll be sharing that in my presentation later on. Also, if you want to do a manual segmentation, the time required is massive. So these are the challenges. One is the resolution of the images. The other is the measurements of quantification, the very limited quantification that we currently have. And the challenges in research in this field are basically difference between the vendors and very limited availability of training data sets and distinguishing between different pathologies. So there comes the role of AI in OCT. And this, just as a joke, this is actually a true email. Radiology, there are so many functions that have been taken over by AI that even when I first looked up AI and the first presentation that was given to me about AI and OCT, the first thing I thought that radiologists are going to go out of business. There's so much that AI can do. So jokes apart, what is AI? AI is a very broad term. Artificial intelligence is a broad term which it is used for any technique that enables a computer to mimic human intelligence and to use logic. Machine learning is one subset in which you teach the machine and then subsequently the machine does the task for you. But the most exciting part in which we are working extensively is deep learning, where you don't really have to teach the machine. You just have to present it certain marked images. The machine learns on its own and then it continuously improves as it goes. So these are algorithms, deep learning algorithms learn. So this is a depiction. For example, if you want computer software to identify a car, in machine learning, you tell the computer, you make a software which tells you these are the components of a car, you find this, label this as a car. Whereas in deep learning, you just give it 1,000 images of a car and it learns on its own what a car means, and then it independently tells you what a car is. Now, whereas the machine learning and the routine artificial intelligence does not learn after a certain time, deep learning algorithms keep on learning as they acquire more and more data, and a lot of times they exceed the human abilities also. The error that we've been seeing over the years in their interpretation and in their identification of features has decreased logarithmically. Now, broadly, AI in ophthalmology has two tasks. One is a classification task. That is a yes/no task. For example, you all must have heard of AI being used to identify diabetic retinopathy. A lot of these large firms are using it. Google, Microsoft, they are all into it. So there they take a fundus image and classify on the basis of certain features, presence or absence of features, into one or the other category. The other and the little more difficult task is the segmentation task, where you take an image and you read the image in the sense that you identify certain features of the image, you quantify them, you mark them separately for presentation that can be used for further studies. So the quality of an image is very important here, and for subjective assessment, it's better to have better images because they lead to avoidance of errors, and for automated analysis, it's even more important. So this is the routine OCT scan quality that we get from 4 of the major vendors: Cirrus, Topcon, Spectralis, and Nidec, which are there in our clinics. So the first task that we did was to first identify the artifacts that can create noise. And this is completely, the motion artifacts are completely dependent upon the speed of acquisition. So when you have a denser scan, it improves your scan quality, it reduces the number of extrapolations that you have to do, but at the same time, it increases the time. So a routine machine, a Zeiss scan takes 1.7 seconds. If you go for the highest machines available now, it takes 0.7 seconds. But if you're going to increase the density, if you want more information, it is going to take 14 seconds. Now, nobody can hold an eye still for 14 seconds. And this directly degrades the resolution and the accuracy of your thing. So this is what I wanted to show. So if you take a raster radial scan, all the areas in between are going to be extrapolated in all your calculations of thickness and of volume. Whereas if you take this, the amount of extrapolation between lines is less. But then there are so many more number of lines also that are being points that are being scanned. If you really want a very good scan, you need to scan with this kind of a density, and this increases the imaging requirements. So can we basically improve the image without having to resort to that? So this was one of our projects. So we estimated the noise in different OCT systems and modeled them into statistical models. So these are the models that we found on kinds of noise in different kinds of machines. And then we verified this using a fixed artificial eye to find out the noise, and these are our results. So if you see the top left corner, that is the original image, and the bottom right corner is the one that we get with our artificial intelligence algorithm by removing the noise. So you get a much better picture after noise removal. These are again examples of the noisy image and of the denoised image using our methods. So these are again two examples. You can see how much better your image quality becomes. So again, this is experimental result on a Duke dataset, and this is on my own Cirrus dataset. The image quality and the layer identifications become much better. The second problem was, once you improve the images, can you do a layer segmentation? Now, layer segmentation is fairly easy in normal images, but when you have distortions, morphological distortions like cysts and all, it becomes really difficult. So we developed an algorithm using AI, which identifies the major layers of the retina fairly reproducibly, and we've got very good results with that. Now, fluid in the retina is present in so many pathologies. All fluid the same: intraretinal, subretinal, and sub-RP. So when you look at the OCT data, it presents your retinal volume. It does not exclude a subretinal fluid from intraretinal fluid. It just gives you a total volume. But you all know that it has different implications. So we worked on this to not only segment the layers, but to segment the fluid spaces in the retina: intraretinal, subretinal, and sub-RP. And we developed an algorithm based on a convolutional neural network. And these are the kind of results. This is intraretinal cyst segmentation. So this is the sample scan in the top left corner. And if you look at the right columns, these are the results that we are getting. In between, the middle column is the ground truth marked by a human observer. So we achieved a fairly good amount of correlation with the human observer. Then we also added certain denoising techniques to further improve it, and we got up to 80 to 83% correlation. This is what results we are getting with subretinal fluid segmentation in CSR cases. We can easily completely identify the fluid and then quantitate it into the volume also. So you can, and here the correlation that we get is almost 90%. Then we integrated all these methods to get a way to quantify all the three kinds of fluid: intraretinal, subretinal, and sub-RP. So if you see the OCT image, the image B is the one ground truth marked by a human observer, and E is what our algorithm is giving. So again, this is an example of a fairly complicated image, but now we are able to identify all the fluid compartments also separately. Again, this is an image of AMD with a fairly distorted anatomy, and you can very clearly identify all the fluid components. Now, what is the utility? So we are going to develop this as a web-based tool, so anybody can upload their images and receive the process output. Till now, 2D segmentation is very easily available, but now we are looking at 3D volumetric data. So when you treat a patient of, say, DME or AMD, you will get to know how much of the intraretinal fluid is reduced, how much of the subretinal fluid is reduced. Is there a particular treatment modality that works selectively on one of these components? So if you have a case that has one particular abnormality in predominance, you can use that modality. All plus in a case like chronic AMD or in a case like retinal dystrophy, you can actually find out the volume of a particular layer, and you will get to know whether that particular layer is less, and you can even make a diagnosis based on that. A very interesting thing is that artificial intelligence is being used to make an octa from a routine OCT image. Even if you don't have an octa machine, artificial intelligence will pick up all the vessel shadows and integrate them, and give you a beautiful octa representation. This software is not clinically available as of now, but I think it's going to be available pretty soon now. So this is about a series of publications for those who are interested in this kind of work with our group at NIT Surat. Thank you so much.